All right, well, while everybody is filtering in, I'm going to get started here. So welcome everybody to today's webinar. I'm Elizabeth Krupinski. I'm the co-director of the Southwest Telehealth Resource Center and the Associate Director of Evaluation for the Arizona Telemedicine Program. Welcome to our Improving Access to Quality Medical Care webinar series. Today it's presented by the Southwest Telehealth Resource Center, the Arizona Telemedicine Program, and our colleagues at Comagine Health. Next slide, please. I would like to extend a special welcome to everybody who's joined today's webinar, especially from our Southwest region here in Arizona, Utah, Colorado, New Mexico, and Nevada. Our fellow HRSA grantees and all other participants from wherever you might be. Next slide. Since 2011, the Southwest Telehealth Resource Center has partnered with the Arizona Telemedicine Program to bring you well over 160 of these very informative webinars. Today's webinar is being co-sponsored by Comagine Health and the Arizona Department of Health. And all of our webinars, including today's, are recorded. And once they're archived, they will be available on our website on demand, and the slides and this recorded presentation will be there as well. Next slide. Now we all got rules, webinar tips and notes here. So I hopefully most of you are probably well used to this by now, but just some reminders. When you joined the webinar, your phone and or your computer was muted by us. We do have time reserved at the end for Q&A, and please use the chat function to engage in Q&A. We do have a post-webinar survey, and we'll bring that up again at the end, but we highly encourage you to go ahead and fill this out. It literally takes 2 minutes or less, but it does give us feedback as to what topics and so on would be of interest to all of you in the future. As already, the webinar is being recorded, and they will be posted as soon as we convert them and everything on the ATP website, which is there, and you should have received the link as well. So next slide. Now it is my pleasure to introduce today's webinar, Telehealth Essentials for FQHCs and RHCs. It is being presented by Trudy Bearden. She's a senior consultant and telehealth lead at Comagine. She received her associate's degree at Northern Virginia Commonwealth College, and then she received a Bachelor of Arts in Biology, magna cum laude, at Florida State University, and Master of Physician Assistant Studies at the University of New England. She serves currently, like I said, as a senior consultant for Comagine since 2010, so it's been there 10 years. She spent a number of years as a clinic administrator, quality coordinator, educator, transformation team lead, IT specialist. She's done a lot, and she has a lot of skills. She understands the challenges and the demands of improving primary care service delivery down in the trenches, in the front lines. Much of her work has been in safety net setting, working with healthcare centers across the nation. She also has a lot of expertise in empanelment, quality improvement, care management, population health management, customer and person-centered service, project and change management, EHR and workflow optimization, and team dynamics. It really is our pleasure to have her here to lend us her expertise on this very important topic. And I'm going to turn it over to you now, Trudy. Welcome.
Thank you, Elizabeth. And I truly, like Elizabeth said, anything related to primary care service delivery, I am so passionate about. And I was thinking earlier, there are few things I would rather do on a Friday than talk to a bunch of people about primary care service delivery, especially in the healthcare, in the health center and rural health clinic setting. Comagine Health is a nonprofit healthcare consulting organization, and I have worked with hundreds of health centers and rural health clinics across the country, literally from Boston to Los Angeles. And I'm really hoping that today brings value to you. I know that there are so many webinars, there's so much information around telehealth, it's hard to keep it straight. And so we're really hoping that today you can come away with at least 3 new ideas to leverage remote healthcare service delivery. And I'm a little bit of a Trojan horse here because we're going to talk about more broadly around remote healthcare service delivery, and some of the things that we're going to talk about may or may not technically fit into telehealth, but we're really taking a holistic view of how can we leverage remote healthcare service delivery to expand access, keep people safe, and then also capture reimbursement. I'm not going to be touching on teledentistry today, and I'm just going to briefly touch about telemental health. So we're really talking about kind of the primary care side of remote service delivery. We'll talk a little bit about like what do we need to have in place to make sure that telehealth sticks around. You know, I know a lot of people are really worried about that. We know that there are legal changes that have to happen, literally acts of Congress to ensure that telehealth is sustained. And we would love it if we can harvest from this amazing group of individuals who have joined the webinar. What are you doing, or what do you think needs to be done to hardwire telehealth? Besides, of course, making the quote unquote pandemic changes permanent, if you can put into chat your name, your organization, and what you think has to happen to hardwire telehealth, especially in our safety net clinic settings, type that in, and towards the end of the webinar, Elizabeth will harvest some of the harvesting and pull some of your ideas and share those ideas towards the end. All right. So breaking news, it's not really breaking news. You know, this is now almost a month old news, but we've been all holding our breaths. If you're an FQHC or an RHC, you've kind of been holding your breath around telehealth because you know that once the public health emergency ends, the waivers end, and it's going to be really hard for FQHCs and RHCs to continue to deliver telehealth services and other remote healthcare services. The current public health emergency declaration ends April 20th, but there are signals that the public health emergency is going to be extended at least through the end of 2021, which gives us a little bit of breathing space to get those things in place that are going to ensure that we can have telehealth sustained and in the long term for our FQHCs and RHCs, where it's actually the most important to have this additional tool in our toolbox to deliver services in our rural and underserved areas. So when I think about, you know, what's the full range of remote service delivery options? There's telehealth, which I'm going to repeat myself probably 3 times about a few things around telehealth specifically. But when it comes to billing and service delivery, there's a discrete set of codes that define telehealth. We'll also touch on the telephone evaluation and management codes, which are only available during the public health emergency. In the calendar year 2021 physician fee schedule final rule, CMS said, as soon as the public health emergency is over, we're gonna discontinue this telephone evaluation and management option. However, there is now legislation in place working its way through that would provide an option for telephone only and have it be reimbursed at greater than the virtual communication services option. This, I think, is going to be key, especially in our rural areas where our FQHCs and RHCs are. When we hear from the front lines, we hear the biggest barrier is the audio portion requirement for telehealth. So I'm really hoping that telephone is going to be a permanent option. We'll touch a little bit on the virtual communication services. So the virtual check-in was available starting in 2019. I got so excited working with my health centers and rural health clinics, and I said, oh my gosh, guys, virtual check-in, you can get paid $14 for a phone call. And, you know, the response was kind of like, meh, 14 bucks reimbursement, not good enough. So now the reimbursement is a little bumped up during the public health emergency, but it would be great if we could continue that virtual check-in option after the public health emergency. E-visits, quite honestly, the rural health centers and rural health clinics and FQHCs that I work with, I don't know many, if any, that are using e-visits, but we'll talk a little bit more about this as an option for you. Chronic and principal care management. I have been promoting CCM, or chronic care management, and now principal care management for many, many years. And there is slow uptake in our FQHCs and RHCs, and that's partially because they don't have the full range of codes to bill for, and so they kind of have a reduced reimbursement, but we'll touch a little bit more on that. The Centers for Medicare and Medicaid Services, or CMS, really wants uptake of these codes, and they've identified certain states where the uptake is very low, like Idaho, and they are now having kind of a concerted effort, kind of working through whatever avenues they can to get these codes up and running, because these services are really important for patients. We'll talk a little bit about the behavioral health integration and psychiatric collaborative care model. I told you that we would touch around the edges around telemental health. I'm only mentioning the interprofessional consultation codes. There's currently no Medicare reimbursement for FQHCs or RHCs, which is really unfortunate. This would really open up the ability to confer with specialists in a way that wouldn't require telehealth, actually. It's kind of like an e-consult option, and CMS has said that they will consider opening this up for FQHCs and RHCs in the future, and I really just have my fingers crossed. And then we'll touch on remote physiologic monitoring, or remote patient monitoring. This is the one remote service delivery that has the most evidence behind it to reduce per beneficiary cost, which is, important for health plans. But part of that reduction in per beneficiary cost is it keeps patients out of the emergency department. It prevents them from being admitted to the hospital and being readmitted to the hospital. And sure, that decreases per beneficiary cost, but you know who it really matters to? Patients. They don't like going to the emergency department. They don't like being admitted to the hospital. And they sure don't like bouncing back to the hospital. So let's talk a little bit about telehealth. So remember, I said, this is really about that discrete set of services. And CMS says that you have to have both audio and video components to telehealth. Each state Medicaid has some forgiveness. So, for example, in some states, the state Medicaid says, well, if your video is glitchy, you can't bill for that visit. There are other state Medicaid agencies that say, if your video is glitchy, or if the telehealth visit doesn't go so well, it's up to the clinician whether they default to phone only. So each state is just a little bit different. And I want to point out the highlighted section on this slide. So CMS says that FQHCs and RHCs can furnish any telehealth service that is included on the list of Medicare telehealth services under the physician fee schedule. Telehealth has been around for decades. So organizations that have been delivering telehealth, they're familiar with that list of telehealth services. Unfortunately, our FQHCs and our RHCs are not. And for now, I actually find that most of my health centers and most of my RHCs that I work with are using the telephone E&M code, because the reimbursement is the same, and it's just easier. But I think we are missing an opportunity. That Medicare list of telehealth services is updated on an annual basis. So CMS adds or takes away services and codes from the Medicare telehealth list through rulemaking. So every July or so, they'll publish the proposed rule, and then in around December, they'll publish the final rule, or November. This year, things were pushed a little late for obvious reasons. But I do want to show you, because I'm a little concerned that our FQHCs and RHCs are not looking at the full range of services that can be provided by telehealth, because you're just using that one code. This is the full list. So this is the list of 250 codes around that are currently available. And you can see that during the public health emergency, the video requirement is listed for some codes, and you can sort the list to see which of those can be delivered by audio only. But I want to point out, and I've highlighted in yellow some of the ones that are relevant for primary care, and I would love one day to just develop this out as a resource with the full description, so you can see they have a very short descriptor. It would be great to expand that description, have what the reimbursement is, a little more detail. But you'll see, for example, that our office visits, so what we call our evaluation and management or office visits that we would ordinarily do in person, CMS has retained the video requirements for those codes. I will also point out that this list is not entirely accurate. So 99201, a new patient visit, office visit, that is no longer available for code to use. CMS removed it in the most recent final rule. But you can see, I just went through this morning really super duper quickly, and I highlighted in yellow, all of the codes that maybe would be relevant for primary care. I've done this before and made a separate resource as well. But you can see that for several of them, you can do the telehealth with audio only, which I think is pretty exciting. Well, the one that I think is most exciting is advanced care planning, which you can do by audio only. So that's what that looks like. I'm going to show you one more thing, and then I'm going to go back to the information on our slides. So you can download that list, which you can tell they always identify the last time they updated it. I'm not expecting that we're going to see many, if any, additions through the end of the year. The other thing I want to show you, which I'm going to cover on another slide, is the Center for Connected Health Policy. So the Southwest Telehealth Resource Center covers 5 states, but if you're from another state, or even if you're from one of those states, this is the resource that I use, I think, more than any other resource. And you can look at your state. So I have Utah brought up. And you can see all the details about what's covered, what's not covered, store and forward, remote patient monitoring. Do they cover remote patient monitoring? And what I love about this resource is if you go to read more, they have a hyperlink to the Medicaid agency statutes. Like, where would I find this? I don't know. I don't know who created this resource, but it's truly, truly amazing. And this link right here, for example, will bring you to the Medicaid statutes. So the other piece of telehealth, specifically that discrete set of services, is that there are distant sites and originating sites. And the distant site is where the provider is, the originating site is where the patient is. I'm going to repeat this. You know what they say, if you want somebody to learn something, you got to say it 7 times in 7 different ways. I promise I won't do it 7 different times, 7 different ways, but I will repeat just a little bit. The geographic restrictions, so peculiar to me. So if you're a patient and you want to receive telehealth services, you have to live in a designated rural area and in a health professional shortage area, which makes no sense. We have urban areas that have health professional shortage areas. CMS used to have a little widget where you could go and put your zip code in. I am excited that that site no longer exists. So if I click on the link that used to be that little widget, it's actually dedicated to something else. And I'm hoping that's signaling that the geographic restrictions are going to be totally lifted and done away with. The audio and video are required for telehealth. It's lifted for some codes for the public health emergency, but CMS has said, the hammer is going to come back down when the public health emergency is over, and you are going to have that video requirement. Reimbursement is the same as for in-person visits. So if you have a level 2 office visit and a patient is seen in the office, the reimbursement is the same if you do that level 2 office visit, which is then a telehealth visit. And people call that payment parity. So same, basically. most of our state Medicaids, if not all, reimburse at parity. And I think we're up to about 29 states that have laws that say that private health plans and other health plans have to reimburse at parity. But, you know, that's less of an issue for our FQHCs and RHCs. For now, you get reimbursed $92.03 during the public health emergency. And CMS came up with that $92.03 by basically taking all of the reimbursement amounts if you were a fee-for-service organization, and they averaged them. There is legislation in the works for if we open up telehealth on a permanent basis, what's the reimbursement going to look like? And so they're looking at the prospective payment system and how they could arrange that so that FQHCs and RHCs can continue to deliver telehealth services. This is just a little table that shows the change from before the public health emergency to after the public health emergency. So we used to have about 100 telehealth codes, and that's really expanded to about 250 codes. And CMS will update that as needed. Again, you know, there's that originating site where the patient is, and the originating site where the patient had to be. And so what FQHCs and RHCs would do is they would be the originating site for a patient, and then somebody else, like a specialist, would provide telehealth to the patient. And early last year, we looked at, because we have access to claims data for Medicare, we looked for all of the states that we cover as a quality improvement organization, and we saw that one rural health clinic just in originating site fees, which are, the reimbursement is like only about $27, had managed to bring in $20,000 just for billing for the originating site fee. Very exciting. Now the originating site can be the patient's home. There's also legislation in the works to keep that allowance or that waiver. Like if you're a patient and you want to do telehealth, why can't you just do it from your home? Why do you have to go someplace else? Makes no sense. And I think it's a barrier for the sustainability of telehealth. FQHCs and RHCs were not allowed to capture any reimbursement. Now they kind of have a flat fee for whichever telehealth code they use, $92. We can deliver telehealth to new or established patients now, which is great. And we have some flexibility around whether a device is HIPAA compliant. For my health centers and rural health clinics that I work with, I tell them, don't get started on something that's not HIPAA compliant because you're going to have to switch eventually. All right, so this is probably the third time, just making the point again that for telehealth services, that discrete set of codes, you have to have interactive audio and video, except for the allowances that we already talked about with the public health emergency. There's always a distant site and an originating site. And the originating site fee is $27 from Medicare. Each state is different. So I know in the state of Utah, for example, Utah Medicaid does not reimburse an originating site fee. That's one of those things that's different from state to state to state. And remember that site that I showed you from the Center for Connected Health Policy with each state. That's how I find out, and I know from state to state who reimburses for that originating site fee for a Medicaid agency. There's a diverse set of providers who can deliver telehealth services, but what I find with my health centers and my rural health clinics that have implemented telehealth is that they have kind of let team-based care fall by the wayside. So you know how we have those awesome workflows in place for pre-visit planning to identify and address preventive and chronic gaps in care. What I'm finding with telehealth is that those workflows are falling by the wayside. So just like our in-person visits, nurses and the care team have an important role as well. And starting in on January 1 of this year, we now have the time-based codes for evaluation and management codes. I'm unsure how that translates to our FQHCs and RHCs, but CMS has signaled that instead of just billing for an office visit, we can now include the work of the care team, which I think is very exciting, and signals that CMS is realizing that healthcare is a team-based affair. So I'm really excited about that. So when I think about primary care and telehealth services, so the FQHCs and RHCs are using the G2025, and you can use that, and it covers a lot of different service codes. You don't have to kind of worry about like what's the CPT code or what's the HCPCS code. You just do your G2025 and you get reimbursed, or the reimbursement rate is $92.03. So the new and established evaluation and management visits, so all of your office visits are included in telehealth. And like I said, 99201 is deleted. CMS is kind of says that those services are rolled up into other services. One of my colleagues has researched and has said that the 99211, which is a level 1 office visit, RNs can do. How that translates to FQHCs and RHCs, I am unsure. I don't think that an RN can do an E&M visit and bill for the $92.03, unfortunately. Advanced care planning, if ever there was a time. So we have patients who are do not resuscitate, do not intubate, maybe they have advanced directives done. But now we have COVID-19. So I might be a do not resuscitate, do not intubate, or what we call a DNR, DNI. But I may say, oh, wait, no, well, okay. So if I get COVID-19 and I go in the ICU, I do want a ventilator. So now is the time to talk to patients about advanced care planning, and this is covered under the telehealth codes, as is transitional care management, which usually for FQHCs and RHCs is you don't have a separate code for it. It's just included in your all-inclusive rate, but you can do this by telehealth now. The initial and subsequent annual wellness visits, these are really important. Although I have to say that the evidence behind annual wellness visits is not as strong now that we've been looking at it, but it is a telehealth code. And I'll show you in a little bit a workflow about how you might look at who's due for advanced care planning and who might be due for annual wellness visits, especially in your Medicare population. Medical nutrition therapy and diabetes self-management training. So MNT and DSMT. So each individual with diabetes comes with a Medicare benefit for hours of MNT and DSMT, but only about 5 to 10% of the time do we clinicians make those referrals. For the FQHCs and RHCs, DSMT and MNT is a little bit different, but these are telehealth codes, and CMS has said that FQHCs can deliver any of the telehealth services. So I feel like this is an opportunity to take advantage of. And then, of course, chronic kidney disease education falls into that as well. Some people are doing some great work doing DSMT by telehealth and even doing it by group visits, so having a Zoom and doing kind of what we do, like group visits when we're at the clinic, which you know how that goes. We have a lot of attrition with the diabetes group visits. But having Zoom can be really helpful, and people like to connect and they can talk about their struggles with diabetes as well, so it's an opportunity. The counseling visit to discuss the need for lung cancer, I've heard that this code is going away or has gone away, but it's one of those things that is available that we just don't take advantage of. And then there are a lot of codes for treatment of opioid use disorder as well. And so there are codes for all of these activities. So providing smoking and tobacco cessation, alcohol and substance use assessment, annual depression screening, which is tied to one of your UDS measures. Technically, you could deliver these by telehealth, bill the G2025, and capture $92.03. I think it's a bit of a stretch, because if you look at what the reimbursement is for fee for service, it's small. It's like $5 or $10 for these codes, but it does create an opportunity, I think. So here's the workflow that I was mentioning. So, you know, if I were in an FQHC or an RHC, you know, I would ask staff to run a report of all of my patients with Medicare. I would identify who is due for an annual wellness visit. I would try to get them scheduled for an annual wellness visit, and I would do a meaningful annual wellness visit, not just kind of checking it off, But our elderly patients, this is an opportunity to do an annual wellness visit, but to check in on them, make sure, how are you doing? Do our prepare tool, look at social determinants of health, make sure they have what they need, check in on loneliness, on how they're doing. Like and this is a way to get reimbursed to do that, but also to touch base with this vulnerable population, talk to them. You could even use this time to talk to them about vaccinations and where to go, things like that. And then, you know, if they're, you can look to see whether they're due for their annual wellness visit. If they're not due for their annual wellness visit, should we be talking to them about advanced care planning and maybe getting a telehealth visit scheduled to do advanced care planning? All right, I'm going to do a time check. All right, so we're halfway through the hour and we've gotten through telehealth and we have a bunch more to go. So check telehealth, we've covered that. And we're going to move to the telephone E&M service. So it's the same code and the same reimbursement as our FQHCs and RHCs are using for telehealth. Only available during the public health emergency. Hopefully we'll have another option that is available after the public health emergency. It's only the physicians or the Medicare providers who can report E&M services or evaluation and management services who can use these telephone E&M services. There is kind of an option if you're fee for service, but you know, it's irrelevant. You could not care less about that. And there are certain, part of the telephone E&M services and the virtual communication services, which I'll cover next, CMS really wants us to use those to keep people from having to come in for an office visit. So they have a couple of constraints. So you can't bill for these services if it originates from a related kind of office visit service provided within the previous 7 days, or if this call then leads to an office visit, whether it's in person or telehealth, you can't bill for this. So I think they really just want you to not be double dipping. So I'm not going to say anything more about that other than to say that most of my health centers and rural health clinics that I work with are actually using the telephone E&M rather than telehealth. I was working with a health center in Los Angeles, and when they were using the telephone evaluation and management code, their no-show rate was 5%. Like, that's amazing for a health center, 5% no-show rate. Most of my health centers have a no-show rate that's usually 15% if they're really, really good, but closer to 30%. You know, we have a high no-show rate in our health centers. They switched to telehealth where they were requiring the audio and the visual portion, and their no-show rate dropped to, rose up, jumped up to 50%. So they went from 5% no-show to 50% no-show. And yeah, that's a number. But what I think about is, what are the patients that didn't get the care that they needed and wanted because, you know, we've got to do telehealth and we have to do the audio portion. So forgive me for that little editorial right there. Let's move on to virtual communication services and e-visits. So there are two types of virtual communication services, and there are the e-visits. I actually don't have any health centers that I work with or rural health clinics that are using e-visits, but it's an option. So we're going to cover it today. And you use the same code. So it's the G0071. And as I said, when the virtual check-ins were launched in, I think it was 2019, I was so excited. But the reimbursement is really low. And a lot of times Medicare will have a new service and a new code, and they'll attach a reimbursement for it. And they'll wait and see, like, is there any uptake or not? And so, you know, if people are not using it, you know, they'll either do away with it or they'll increase the reimbursement, which is what they did for fee-for-service with the transitional care management codes. I should probably say I'm not a coding expert. I'm not a coding expert, but I play one on webinars. So anything I say about coding, make sure you check with your billing expert. Double check me on everything. So the virtual communication services and the e-visits, you know, CMS has bumped up the reimbursement to about $25. And for virtual communication services, there's the virtual check-in. So it's about 5 to 10 minutes of medical discussion. The goal, of course, is to keep a patient from having to have an actual visit. So instead of reimbursing $92, you can handle something for about $25. There are new codes that are, there's a new code that allows for a virtual check-in that is 11 to 20 minutes. I have searched all of the final rule, all a bazillion pages of them, and they don't mention whether this additional code and time and enhanced reimbursement is available for FQHCs and RHCs. We're just going to have to stay tuned. So I think for now, just think about the virtual check-ins for the 5 or 10 minutes, and then the remote evaluation of the pre-recorded patient information. So I'm a grandma ×3, and my kids will send me pictures of things that have happened to my grandkids, like somebody slammed their finger in a door, and I'll get this picture that'll say, Mom, and my kids call me Dr. Mom. I'm not a doctor. I never play one, even on a webinar, but I am a physician assistant. And she will, my daughter, for example, will send me a picture, and she'll say, oh, look, Mason slammed his finger in a door. Do I need to get sutures? And so this is kind of the equivalent for that. So you can do it a remote evaluation of pre-recorded patient information. I think it's an amazing option that is just so underutilized. Like when you think about how to operationalize it, like how do you let patients know that there's this option? I really think that if we want uptake, it's going to have to be the clinicians messaging this to patients in the exam room. Like, you have this infection on your arm. I want to see what it looks like in the next 3 days, but I have this option for you. You can take a picture and you can text it to me. I have secure texting. I think this is an amazing opportunity for expanding the services that we do. I used to be on a vascular surgery service. I would love this for a post-op follow-up. Like, I want to see what your incision line looks like, or do we have infection? So that the patient doesn't have to come in just for me to look at something. So I think this is a really great option, which is underutilized as well for a remote service. So we're going to talk about e-visits. I'm going to kind of gloss over it. Like I said, people just don't seem to use this very much. And when I think about, what would an e-visit scenario be like? It would be like a patient has a cough, and they want to know, do I need antibiotics? So they might use the portal to send me a message and say, hey, I have this cough, it's been hanging on for a week now, do I need antibiotics? And that puts the clinician in a difficult situation because I don't have enough information. Do you have a fever? Have you been exposed to anybody? Blah, blah, blah. We do know that, upper respiratory infections are 80 to 90% of the time, they are from a virus. Hopefully it's not COVID-19 virus. And you don't need antibiotics, but that would be an example. I think also if somebody is having urinary tract infection symptoms and they just want to say, hey, I'm having these symptoms, can you call me in an antibiotic? I think it would be really, it would be an option. And maybe not a lot of patients would take advantage of it, but even back in 2006, I did secure messaging with my patients. And sure, only about 10 to 15% of my patient panel used it, but the people who did use it really, really appreciated it. And I was able to keep people out of the emergency department. All right, so we're going to move on to chronic and principal care management. And I'm going to gloss over this because I provide in-person and webinar trainings on chronic care management and now principal care management. And I could talk to you for an hour or two. You probably don't want me to do that. So we're really going to gloss over it. But this is an underutilized option to keep patients safe. 50% of Medicare and Medicaid expenditures come from 5% of beneficiaries. And it's only a matter of time in primary care before health plans, Medicare, Medicaid, and other health plans are going to require that we identify who that top 5% is and manage them a little bit better, provide some enhanced services. We call that care management. And for now, we can actually be reimbursed for it. And this is so underutilized. It is such a shame. So for chronic care management or for principal care management or for behavioral health integration, these are all very similar services. It's one code and the reimbursement is $67 per month per beneficiary for providing 20 or more minutes every month of services that are kind of like chronic disease management, care coordination, and care management. When I think about a traditional care management program with an RN or a registered nurse who is providing these intensive enhanced services to patients, this isn't really always like that, but it does provide this opportunity. And I will say that my health centers and rural health clinics always ask me, like, how do I get reimbursed for social worker time? Like, this is an opportunity for that type of reimbursement. And it's virtual. It's a phone call to the patient for 20 minutes or more. The biggest drawback for this is that patients still have to pay their 20% copay. And so CMS is actually considering, there's a lot of pressure for them to do away with that copay. But the chronic care management is multiple, 2 or more chronic conditions expected to last at least 12 months or until the death of the patient. And Medicare estimates that this is about 2/3 of Medicare beneficiaries. So could you do a back of the napkin calculation and say, okay, so I have 1,000 Medicare patients, 2/3 of them have chronic conditions, and they qualify for chronic care management. If I take that number times 12 months times $67, what's my income? And there's a lot of money to be made here. There are vendors who will provide chronic care management services for you, and they'll keep a piece of the pie. Any one of you who are from health centers or rural health clinics, you can do this. You don't need to sub this out. You can have a well-trained medical assistant do this, and it's huge for patients. And starting this year, you can do principal care management. So CMS has seen fit to expand this to our health centers and rural health clinics. And that's to provide monthly services to an individual with a single high-risk disease. There's a lot more. So we are like truly touching the tip of the iceberg here. But, again, I would probably start looking at, like, now more than ever, this is the time to be doing outreach. This is a way to do it. This is a way to enhance services to our patients. I would look at my panel and I would see who should be receiving chronic care, principal care management, and I would get it started. So really tiny font, but if you want to delve in past the tip of the iceberg, like I said, I'm kind of like a Trojan horse. Like, does this really fit under what we would call telehealth or telemedicine? I would argue yes, other people would argue no. But if you want to delve in past the tip of the iceberg, when you get the slides, you will have that information. Behavioral health integration is like chronic care management and principal care management, but provided to like any mental health diagnosis. And then there's the psychiatric collaborative care model, which is amazing. But you do require a psychiatric consultant, which most of my health centers and rural health clinics just don't have. And any chance that I get to talk to a state Medicaid, I tell them, if you want to expand mental health services, provide that psychiatric consultant to the health centers and rural health clinics in your state so that they can provide that collaborative care model. And unlike the behavioral health integration, which where you can do that 20 minutes with the patient, the collaborative care model really is a team. So it has to include the treating provider, a behavioral health care manager, and that psychiatric consultant. All right, so we're getting close to the end. I'm just going to do a quick time check. We're doing well. We're about at 3/4 of the way through the hour. And we have really only one final topic to discuss: remote physiologic or remote patient monitoring. Thus far, CMS has not seen fit to include our health centers and rural health clinics in reimbursement for remote physiologic monitoring, or RPM. They have said that they will consider this in future rulemaking. And because the evidence is so strong behind this telemedicine piece, which this does technically fall under telehealth and telemedicine, I think we're going to see this open up for more for health centers. So that's with Medicare. Each state Medicaid either does or doesn't reimburse for remote physiologic monitoring. Sometimes they do and they don't know it. So there's the state statutes may not say whether they provide reimbursement, but sometimes it's worthwhile checking with the state Medicaid. And a lot of my RHCs and health centers say, well, I don't want to do telehealth if, you know, the waivers don't continue. Well, that's for Medicare telehealth. Almost all of our states reimburse for telehealth and for other remote services. So you can't just kind of throw up your hands and say, you know, why would I even do this if, you know, things might get, you know, pulled away after the public health emergency. You still have your state Medicaid agencies that are paying for telehealth. So opportunities. So these are the states that are covered by the Southwest Telehealth Resource Center. And you know where I got this information? I went to that website from the Center for Connected Health Policy. Arizona, very clear. They reimburse for remote patient monitoring in their fee-for-service program. To me, this says not for FQHCs and RHCs. Colorado, it's hard to tell. They don't mention it. Nevada, New Mexico, same. Utah does for cardiac monitoring, but you require prior authorization. In my state, in Idaho, they don't cover it. Unfortunate, and I know that this is going to change. It kind of has to change, I think, honestly. And I will say that, sure, you know, remote physiologic monitoring or remote patient monitoring, you know, can we be a little creative? So CMS thinks that remote patient monitoring goes under your all-inclusive rate. Sure, okay, so yes, you could do that, but you know, you can do that under chronic and principal care management as well. So if somebody needs remote patient monitoring, you know what, you can do it under chronic and principal care management. And remote physiologic monitoring technically is kind of transmitting like using Bluetooth technology to transmit results. If you're going to do, you can be creative with remote patient monitoring. So if you're doing it under chronic and principal care management, somebody has hypertension and they're doing a blood pressure log for you, that's kind of like remote patient monitoring, just kind of putting a creative and expansive spin on it. And that could go under chronic and principal care management. There's also a possibility of self-measured blood glucose or blood pressure and continuous glucose monitoring. One of the health centers that I work with has very bravely partnered with a vendor for continuous glucose monitoring. They're using the codes that they get the guidance from the vendor. So the glucose monitoring vendor has said, you can use these codes, and they have been billing them and they have been getting reimbursement. So, you know, I put a question mark there. You know, would Medicare, Medicaid, or even a health plan reimburse for some of these services? I have included the FQHC and RHC remote patient monitoring toolkit, which is really great. And the American Medical Association has a remote patient monitoring playbook, but they call it the Digital Health Implementation Playbook. You have to know that it's actually an RPM playbook, and it's actually quite decent. I'm not sure how relevant it is to health centers and RHCs, unfortunately. So this is just a look, as kind of a snapshot, a bird's eye view of kind of what are the things that I would think about for health centers and rural health clinics with regard to remote services, and how you could expand your services to patients, check in on them. Like, if ever, the CDC has already released its concerns with delayed care. So people are delaying their care that really need to be seen. Like, if we need to be proactive, we're primary care. We're not, this is not acute care services, primary care services. We accept responsibility for our patient panels. Sorry, a little passion coming through there. This is another kind of look at how can you apply those things like the virtual check-in, the e-visit. And I really want to move us on to the key changes for sustainability. So, you know, leadership is super number one. If you don't have that, there's no, you know, I always ask, what's your telehealth perspective? So do you see telehealth as a stopgap until the end of the pandemic? And if that's the case, then, you know, it's not sustainable. You know, what is your organization's telehealth perspective? Like, could you kind of test the water and see what it is? Do you have a strategic plan? I think people overthink it and they think, oh, we need this huge budget. You know, if you have a computer with a mic and a camera, and you have some sort of way to connect with patients using Zoom or Doxy.me or whatever, It's not that complicated. One of the biggest barriers I see in my health centers and rural health clinics is staff buy-in. I have clinicians who still are dragging their feet and saying, I am not doing telehealth. I don't know how people tolerate that, but it's happening. Training, training, training. It's something we have to just become experts in. The demand, we're going to see demand fall. Yeah, sure. But for those few patients that really like telehealth, we should keep it going. Reimbursement, you have to be getting it at the organizational level, and at the federal and higher level, we have to be able to reimburse our health centers and rural health clinics. The rules and regulations have got to change for this to be sustainable. There's no doubt. We also have to have team-based care. So going back to our principles of in-person visits where we have true team-based care. I mean, how long have we been working on implementing team-based care? Let's not let it fall by the wayside. We have to walk in our patients' shoes and ensure that telehealth meets their needs. And you know what they say about location, location, location. When it comes to telehealth, it's workflow, workflow, workflow. We need to make sure that we have quality assurance. Does everybody have the same high quality experience? And are we measuring, like that one site that I said, they're measuring their no-show rate. Are we making sure that our colorectal cancer screening rates are not falling, that our A1C rates are not falling? All of our UDS measures, what's the impact of telehealth on our UDS measures? And other measures if you're a rural health clinic. And I'm sure I'm missing a ton of those as well. All right. So we have about 10 minutes left for questions and harvesting. So Elizabeth, I'm going to turn to you and see if you were able to harvest the wisdom of the crowd. And what pearls have you identified to share with us?
Yes, so I was able to harvest, and there were 6 areas that rose to the top. The number one most common was getting broadband into rural areas. That's number one. And then number 2 and 3 are tied. Payment parity, not surprisingly, tied with technology, tools, infrastructure, that kind of stuff. And then the more sporadic ones were cross-state licensure, the need for data on outcomes and cost, and integrating care and workflows more post-COVID between in-person and telemedicine. So a lot of the stuff you touched on, and these, boy, I've seen these in so many different ways, and they are the top ones always. So that's great. Let's get to some questions. So there was a list that you provided at the beginning, the covered telehealth services during the public health emergency, I believe was the list. I'm going to put that I have a link. I just put that into the chat, and that goes straight to the CMS website. And I believe that's the one that you were referring to. So that should be there for everybody. Oh, let's see. We have a lot of good questions. So that was the link. All the slides, by the way, and the recording is going to be out there. So you will have everything, and hopefully by the end of today. Let's see. PowerPoints. Link.
So while you're looking, I'm gonna cover the broadband question a little bit. So there's a lot of money being put behind expanding broadband, and the Federal Communication Commission, or the FCC, has broadband maps. They are notoriously inaccurate. So if in a census area there's one house, for example, that has adequate broadband, they say the entire census tract has it. I will say that I look forward to community-based solutions to poor broadband. So instead of it just being us kind of doing telehealth, what if we had telehealth nodes? Like a dedicated space in a library, for example, where patients could take a telehealth visit where they had broadband, a computer, a camera, a mic, reliable internet, or our centers for the aging, or the YMCA, or I think that the solution to broadband is, yes, there's a ton of money behind it, and there are like the last mile campaigns, but we have solutions at our fingertips now, I think, that we should be leveraging to take a community-based approach to the bandwidth problem. And I hear that about the cross-state licensing. Some states are very proprietary and they don't want people who are out of state to be coming in because it creates competition for their providers. And that's really, really unfortunate for the mental health field. So I'll shush. Other questions, Elizabeth?
Yeah, pretty specific. Can we bill the EM telehealth visit in addition to smoking and tobacco cessation? In other words, bill 2 units of G 2025 if both are performed during the encounter?
That's a really good question. I don't know the answer to that, and I'm not sure how to get the answer to that. I'm assuming the answer is going to be no, because, but I will see whether I can find anything that actually forbids it. There are a lot of resources very specific for FQHCs and RHCs around billing and billing that code. So let me check that, and we will, if I find that answer, I will put it in the slide set that will go out to you.
Great, thank you. Yeah, my gut reaction was no, it's double dipping as well, but who knows? Clarify, I thought the annual wellness visit had to be an AV visit, real-time video, not just a telephone visit. Is that correct?
If you look at that list of 250 codes, interestingly, the annual visit codes and the IPPE, so the Welcome to Medicare visit, CMS states can be audio only.
Okay.
I'm really surprised that that is audio only, whereas our office visit E&M codes are not audio only. But if you're in doubt, go to that list, check my work, find those codes, and see whether it says yes for audio only.
Okay, we got a lot. We might not be able to get to them all here because we got 3 minutes left, but we will answer them afterwards and get them out there to everybody. But we can do a couple more in the last couple minutes. Do you have any updates on CPT 92229, $55, as it relates to FQHCs and RHCs being able to use this new 2021 code?
I don't know. Can you tell me what that code is again?
Where did it go? 92229.
Right. So I'm not finding it on the telemedicine spreadsheet. I'm not seeing it as a code that is covered.
Okay. Let's see.
And if they're listed sequentially as well. So if I look for 9.2, so on the fly, let's see.
Yeah, no, it wasn't.
9.2.2, not seeing it listed on the telemedicine codes, on the telehealth codes.
Okay. Is there a difference in reimbursement between uncapped RHC versus capped RHC for state and federal? Well, federal you could probably answer, but each individual state's probably going to differ.
Yep. I'd say each individual state will differ. So, check with your state Medicaid agency and or each health plan. The health plans are actually really good. So if you want to know what a health plan does with regard to telehealth, you usually go to their website. But CMS does not specify any difference in the reimbursement rate between capped and uncapped.
Okay, someone read there was a retroactive rate adjustment for G 2025, updated rate of $99.45. Do you know if this is on or after January 1st?
I don't know, but we will be sent one of the resources that are listed in the slides should have that information, the retroactive reimbursement.
Gotcha. Okay, like I said, we do have a whole bunch more questions. There's about 12 more, not a whole bunch. There's about 12 more questions, and we're not going to be able to get to all of them here. So if you could go and kind of proceed to the last slides. Again, we will try to get all these answers out there for everybody. We'll download the chat, and we will collaborate here with Trudy to get those answers out there. So this presentation has been brought to you by Comagine Health, the Arizona Department of Health Services, the Arizona Telemedicine Program, and the Southwest TRC. You can check out our website there for upcoming events, and you can get to our recordings as well. And next slide, as always, we greatly value your opinion. Please take a few minutes, the sooner the better, because after you leave here, you're going to forget in 2 minutes as you go get your coffee or go to the bathroom. So maybe take 2 seconds to fill out our survey. It's quick, it's online, and as you exit, you will be taken directly there. You don't even have to do anything. So thank you all very much, and thank you, Trudy, for this wonderfully informative webinar today. And to all of our attendees, enjoy the rest of your day.